Hi, my name is Jana Leto, and I'm a Policy and Regulatory Affairs Manager with the California Telehealth Resource Center. This is our last session in a three-part Spark series going over the digital health updates in the recently released calendar year 2026 Medicare physician fee schedule final rule. In this session, we will be talking about updates related to artificial intelligence and digital health. Before we get started, I have our disclaimer. CTRC does not provide legal advice. All materials are strictly for informational and educational purposes only. We strongly encourage you to connect with your own billing and compliance teams to determine if the updates we cover in this session may impact your organization. Before getting into the material for the Spark session, I wanted to level set how we're going to walk through all the digital health updates in the final rule, as things can get confusing fast when we start talking about payment for digital health updates. So we're going to be using the same simple framework that we've used in our previous two sessions to make sure the information is clear and consistent. And there are three questions we need to consider before we talk about coverage, coding, and reimbursement. So the first is what modality we are talking about. And for this session, it's AI-enabled services. The next is which provider types. For this session, we'll be focused on providers covered under the physician fee schedule, but we'll also be talking about inpatient prospective payment system and outpatient prospective payment system providers, as well as FQHC and RHC providers. And then our payer is Medicare, and this is important to note as AI-enabled services can be reimbursed and considered differently by different payers. So making sure that we level set and that we know we're talking about our payer as Medicare. So this is our last session in this three-part Spark series. We covered updates related to remote physiological management, RPM, remote therapeutic management, RTM, and for Medicare telehealth in two previous Spark sessions. I encourage you to visit the CTRC and YouTube to learn more about those and watch those videos. So today we'll be talking about updates related to AI in the Medicare physician fee schedule final rule that was issued this Halloween and will become effective on January 1, 2026. But I do want to flag that we'll be also talking about how CMS covers AI and two other payment systems, the IPPS and OPPS as well. So before diving into details, it's worth noting why AI matters. So Medicare already pays for a number of AI-enabled services, and these tools help clinicians diagnose disease earlier, manage workload, and extend specialist-level capabilities into routine care. And so Medicare pays for AI through different payment systems. So for the physician fee schedule, we have the outpatient hospital system, OPPS, and then we have the inpatient hospital system, which is under IPPS. And AI is paid according to the rules of each system, not as a standalone category. So in the rest of the Spark session, we'll walk through what AI services are covered under each payment system and how Medicare goes about paying for them. And then we'll go over what CMS actually finalized in the calendar year 2026 physician fee schedule final rule and what's covered there. So first up, we have the physician fee schedule, and you'll see on the left, these are the AI services that Medicare pays for in physician offices and in clinics. The three that you first see are codes that CMS has formally activated through National Physician Fee Schedule evaluation done via rulemaking, and they are fully payable nationwide. So first up, we have the Autonomous Diabetic Retinopathy Screening Code of CPT 9229. Then we have the AI-based coronary flow analysis code of CPT 75580. And then new for 2026, that was just finalized in that PFS, is the automated coronary plaque analysis. So providers that are paid under Medicare physician fee schedule can start be billing and being reimbursed for this service starting January 1, 2026. Then we also have additional AI imaging codes that exist in Category 3 CPT code status, but coverage varies by region as determined by MACs. So overall, these AI tools are billed with their CPT codes, just like any other services for physician offices. And then we have a value spotlight on the right, going over the value of CPT 9229 for FQHCs and RHCs. And CPT 9229 is that autonomous diabetic retinopathy screening CPT code. So value actually lies in quality measure compliance, as it satisfies two measures for HEDIS and for MIPS. You can see those measures there. And then in terms of payment, FUCs and RACs are typically received um, encounter-based payments, so under the PPS or the AIR respectively. But under certain circumstances, they can opt to build a technical component for the CPT 9229 separately to their max. And the payment for that can go up to $43.67. Do you want to note that from an FQHC and RAC perspective, this may involve a high administrative burden relative to the payment, mainly due to the high effort that might be needed to segregate the claim from the encounter. So how does Medicare pay for AI under the PFS? AI fits into the same payment structure used for everything else under the PFS. There are three different ways that it can happen. So we have AI diagnostic tests, say some AI tools operate a standalone diagnostic test. So for example, like the AI diabetic retinopathy screening, they get unique CPT codes, and once CMS assigns a payment amount to those codes, clinicians simply bill them like they would any other test. Then Medicare pays the rate tied to the code, which is already includes the cost of the AI analysis and any related equipment. CMS thinks about three things when they set payment for this, which is one, the cost of the tool, thinking about how much the camera, software license, or cloud service costs. They think about the workflow and how the test fits into a typical visit, whether the staff has to set it up or the clinician needs to review the output. And then specialty use, thinking about how often service is used by clinicians in real practice. Then the second option is AI used inside a procedure. So sometimes AI is used during a service, like an AI polyp detection during colonoscopy. And in these cases, the AI isn't billed separately. Instead, it's considered part of the tool or supplement used to perform the service. So the practice is built into existing post-practice expense, just like equipment or software inputs. But there's no new code and there's no separate payment. The value is built into the existing code. Then we have AI's practice expense inputs. So some AI software does not get its own CPT code at all. Instead, CMS assigns a cost of software as an equipment or supply input inside a different service. The software is wrapped into the per service payment as part of the practice expense, and the clinician doesn't bill anything separately for AI. The important thing to note is that AI is still paid for, just not separately, and the cost is rolled into practice expense RV, relative value units, also known as RVUs, for that service. Next up, we have the inpatient prospective payment system. So AI is covered by a new technology add-on payment, also known as NTAP. These are the AS systems on the right that Medicare has approved for temporary add-on payments of NTAP in the inpatient setting as finalized in the fiscal year 2026 inpatient prospective payment system final rule. These focus on neurology conditions where rapid detection can change outcomes. And Medicare only grants these payments when technology offers meaningful improvement over current practice. So in terms of how Medicare pays for AI under the IPPS, they do it in two main ways, either through NTAP or as part of the regular diagnostic related group, DRG payment. NTAP is designed to help hospitals cover the cost of new innovative technologies that are more expensive than standard of care. They are temporary, so they last for 2 to 3 years while technology is new and hospitals are still adapting it. And to qualify for NTAP, the technology has to be new and expensive enough that the usual DRG payment doesn't cover it. And it has to show clear clinical improvement compared to what's already available. Medicare doesn't typically cover the full cost. It pays up to 65% of the technology costs or 65% of the extra cost above the normal DRG payment, whichever is less. There's also a special pathway for devices with FDA breakthrough status that they can qualify for NTAP even faster. Next up, we have the outpatient prospective payment system, the OPPS. In outpatient hospital settings, AI tools are already in use. So you can see a listing here of certain AI-enabled services that are under new technology ambulatory payment classification, so new tech APC. Medicare covers them as part of the procedure payment, and AI doesn't get a separate line item when used in hospital outpatient departments. So I wanted to flag here that you can see if there is, I'm gonna move my head a little bit, but if you can see 2 stars, these AI-enabled services received updates in the calendar year 2026 OPPS final rule. And so how does Medicare pay for AI under the OPPS? So We have new TAC APC, so under the outpatient prospective payment system, which bundles most costs, including AI, into the APC payment for the procedure. So that means the AI is covered but not separately billed. Over time, as AI becomes standard practice, CMS updates APC rates to reflect increased use of the technology. And it has similar timeline considerations as MTAP in the inpatient setting. Wanted to flag that early outpatient payment can support later coverage in the Medicare physician office setting and vice versa. So we'll be going over the specific updates that are in the calendar year 2026 Medicare physician fee schedule. So first up, this is just to go over comments related to software as a service. So there were comments related in the RPM and RTM section that specifically asked CMS to create new RTM and RPM codes specifically for software as a service or AI-driven analysis rather than limiting codes to provide or perform analysis. Commenters also asked CMS to update practice expense inputs for remote management to reflect modern technology costs, including software as a service platforms and AI-generated analysis. And then CMS also had a comment opportunity on payment policies for software as a service, and they asked commenters on factors to consider when paying for software as a service, whether they should use OPPS-based pricing strategies on how to value physician work, data sources, or also the use of these in chronic disease and assessing quality, safety, and efficacy. Overall, folks commented, but CMS did not finalize a new software as a service payment policy and will consider comments that were submitted for future rulemaking. There was also an update in the Medicare Diabetes Prevention Program, which is the launch of a new asynchronous online option starting January 2026, where beneficiaries can participate at their own pace using a smartphone or web platform. CMS requires at least some live human coach interaction and explicitly said that AI or chatbots don't count. They created a new payment code for this new online asynchronized option, and they also said that mixing and matching online and synchronous sessions are not allowed from the same beneficiary. There's also no changes to performance bonus, and makeup sessions can now be delivered online also. So that brings us to a close to our AI-related updates. This was our last Spark session in the series going over the digital health updates in the calendar year 2026 Medicare physician fee schedule final rule. We encourage you to visit the CTRC website and our YouTube to either rewatch this recording or catch the previous recordings that went over the remote physiological management or the remote therapeutic management updates or the Medicare telehealth updates. If you have any questions about today's session or if you have any feedback, please connect with us using the QR code here. And thank you again for joining us for the series. We hope to see you for our future series with CTRC.